a lot of time is spent, by the available human resources outside service provision. And so addressing that will help us in many ways in ensuring that our health human resources are adequately utilized. So what do we do? What are the things that we want to do as the Federal Ministry of Health going forward? We are focusing, number one, on incentivizing healthcare workers to stay. Number two is to train more healthcare workers. Like we already identified, there are a number of, we do not produce more than 3,500 healthcare workers, medical doctors every year from all the 46 accredited institutions. What that says is that we can train more people. Recently, the government has established several universities of medicine, and health sciences so that we can train more healthcare workers. Now, while those have been established, we need to also we are also working. I just came in from a meeting in the Ministry of Education. We're looking at how we can, utilize those institutions and ensure that those who train them stay back, and they're able to train them. Right now, we realize that most of the medical professors or the lecturers in medical school are actually being recirculated around several institutions. So that's for us is something we need to address to make sure that we're able to attract more trainers. And so the issue of the diaspora trained doctors, well, diaspora in two parts. One are the people who are already working, diaspora healthcare providers who are accomplished in many ways. So we're looking at how we can mobilize them so that they can contribute, number one, to healthcare provision, service provision, maybe 3 months in a year or certain times of the year. A lot of them are actually willing, to come back to Nigeria and contribute their services. They just need to have something more organized so that they can also, they'll be able to arrange their own existing itinerary around this more organized setting. The other one is the use of digital health, use of ICT to make sure that we harness this capacity of these other brothers of diaspora and in other places, to provide services digitally, through digital health, or what we call telemedicine in the health sector. That's one aspect of the diaspora. The other aspect are those who are trained. We have so many young doctors who have been trained abroad and they come back to Nigeria, they go through the Medical and Dental Council, pass the exams, and then get certified to practice in Nigeria. We realize that the number of people who actually come back in that category are over 1,500. What that says is that we actually have a significant number of people who are training abroad. These are people who would probably have been trained in Nigeria. They could not get admitted because of the restrictions in the admission the criteria. So the next thing we're working on, can we increase the capacity of the existing institutions to train more healthcare workers without losing the quality of the trainees that they give to them, that they're able to produce. So we're working with, recently we had a consultation with heads of faculties of medicine across all the teaching, all the federal tertiary institutions that have colleges of medicine to look at what is possible. Just an ongoing conversation to look at what is possible. Of course, they will not be able to. We're also working with the Medical and Dental Council of Nigeria to, harness these opportunities. So, but being able to train more people is certainly a critical aspect of our response to the human resource crisis. The number of people we are training now is not much more different from the number of people that were trained 5 years ago. So we need to now begin to match our capacity to increase number of health care workers that we are training, we're able to train with the increase in the population. While we already have a shortfall that needs to be met, the population also continues to increase. And in the midst of that population increase, we have our people living. And then finally, while we're addressing the issues around migration, we must begin to acknowledge that certain professions, certain professions need to have the impact of certain professions or lack of those professions have a certain kind of impact in the population. And so we must begin to address the issues of remuneration. How are the people paid? I mean, like, I tell a popular story about what happened in my department the last, if you listen to me in the last 3 months, you probably have heard this story. I tell it all the time because it hits you bang in your face. What is that? The story is that in November 2021, a cohort of 11 doctors were sent to my department. We're very happy, to have them work in the department and, help to strengthen the health system. However, by February 4th, 2023, by February 4th, 2023, by January 4th, 2023, which is not 2 years later, it's like a year and maybe a month or two, the last of the 11 have left. They have left. Why it's significant is that because this group came as a cohort of presidential awardees. So they are very knowledgeable, very enterprising, very smart, and very upwardly mobile. So really the kind of people that the system needed, public health, healthcare financing, health policy, but all of them were health workers, mostly doctors. They came as a group and they left. And on one of the boards that I had, been privileged to work on, one of the meetings, a subspecialty, a very, very, critical subspecialty that, requires many years of training and qualification. In 1 week, everybody left. They left, like the head of department, everybody from the head of department to the senior house officer left. I suspect they went to the same place, so there was an emergency to respond to all of that. So we are also looking at how can we, address the issues that make people leave in terms of salary, in terms of remuneration, in terms of incentives, other incentives, promotion, training, and also being able to provide, like staff quarters, for people in the not so urban areas. Now, when we talk about the external determinants of health outcomes, the issues around security play a lot of role. We also have the issues around infrastructure, not just within the hospital or the health centers, the infrastructure like schools, like electricity, things that contribute to the well-being of individuals. And of course, ability to purchase the kind of quality of life that you feel that you are entitled to. So those are things that are outside the health sector, which webinars like this will mobilize everyone around ensuring. And then, of course, we come to the issue of insurance and making sure that everyone is insured and insurance is able to pay. When we have insurance paying for services, and paying promptly and paying, as insurance is supposed to function. And I thank God for the National Health Insurance Authority Act and those that are managing it. What it does is that it helps to create the kind of opportunity that people can take outside the public sector, well, within the public and private sector. For instance, you can actually set up care institutions and agencies in the rural areas, okay? What that does is that your payment is guaranteed. So with or without other sources of income, we are able to expand our healthcare space. So that also is an area we must continue to pay attention to, and we as government are paying attention. That's actually why we had to review the National Health Insurance Scheme Act to develop the National Health Insurance Authority Act, which creates a special fund for the vulnerable and all of that. So that way you have an expanded pot of money, as it were, that can pay for additional risks. Okay, so that people who healthcare providers can have additional access to funds, to pay for health services. Okay, so we are currently planning a number of things that the Minister of Health wants to do before he leaves. Number one is to increase the capacity of the health sector to coordinate and to respond. Which is now to designate the Human Resources for Health Unit as a national program in order to help us respond. And of course, we hope that we can have a national Human Resource for Health Summit before the administration ends. Thank you very much, and God bless you. I think my time is up.
Great. Thank you very much, Dr. Azodo. This was a very, very rich intervention, and I think the recurring theme that came through your thoughts were just the intersectionality of the challenge, right? So it's not isolated or siloed, but we need sort of a comprehensive solution with government in the lead, but that includes the private and social sector to really drive this forward. Thanks so much, man. Your comments were so rich. I'm sure we'll come back to you in the Q&A. But if we could move on to our third, or before we move on to our third presenter, I think the ACIOE team would like us to take a quick break just to take a picture of the panelists. So panelists, if I could ask you to turn on your camera so we can get a picture of those who are speaking. And then after that, we'll move on to Dr. Ojo. I don't know, is he on WHO? Okay, yeah, Dr. Ojo. All right, are we good? ACIA team, are we good to move on? Okay.
Yes, we are. Yes, we are.
Yes, we are, Jonathan. You can go ahead. Thank you.
Okay, perfect. Yeah. Thanks for that. All right. So moving on to the third presentation, we have Dr. Olumuyiwa Ojo from the World Health Organization. And here's a brief bio on Dr. Ojo. Dr. Ojo is the Technical Officer for Human Resources for Health and Self-Care Interventions at the World Health Organization Nigeria Country Office. He's a public health practitioner with over 15 years of experience at various levels of healthcare delivery, leading various health system strengthening interventions with reproductive, maternal, and child health programs, implementation research, HIV and AIDS, TB, and malaria projects. He provides technical support to the government at all levels and partners in the development of policies and strategies on HRH and SRH. He's a conference speaker and thought leader on health and development and has a really strong understanding of the Nigerian climate. So Dr. Ojo, we look forward to your technical perspective on the challenge, which I'm sure will reinforce what has been spoken about and maybe shed some new light to what our two previous speakers have provided. So over to you. Thank you very much.
Thank you so much, Mr. Gege. And I want to first thank the organizers for inviting us, and also thank the previous speakers because they've made my work very easy. And this is what we need. We need the sustained discourse on human resources for health health in Nigeria, so that we can reach out to all the people that we need to reach out to. There are a lot of discussions going on already, but we need discussions that are rich in facts and figures rather than those. I mean, it's great to have those passionate discussions, but most importantly, we need something that speaks to facts. And I think those two speakers have on these topics. Can I have my slides? So today I'll just be enriching the discussions that we've had before. I'll be concentrating on training, a lot on training, a bit on recruitment, and I think Dr. Azodo did justice to issues around retention and the knotty issues of migration. And so I'll just pick a little bit on that in the next few slides. I'll start by next slide to say that just like previous speakers said, there's no, next slide. There's no health sector without, or health system without human resources for health. It's the central glue that holds all the building blocks of health together. And the capacity that we see in the health system, or the level of our health system, reflects on the level of our health workforce. They are the same level. As you have heard, major challenges, I group them generally in two areas: shortage and equitable distribution of health workers, and the ones that are available, how well are we using the health workforce that are available? And that is a result of several factors, including poor HRH planning, uninformed or policy decisions that do not have evidence to show. And those are things that have kept us where we are right now. We don't also have very good strategies on recruitment, attracting talents, and keeping them. And our training capacities are also inadequate in a way, not in terms of numbers, but in terms of what goes into those trainings. And those challenges have resulted in those disparities that I will be showing you in the inequitable distribution of health workforce in the north and the south of Nigeria when you compare, and also rural and urban distribution of healthcare. And also when you look at different levels of healthcare, primary care, which should take care of most of the issues, now have very few qualified health workers of the right mix to take care of the healthcare problems of Nigeria. And that's why people are losing trust in our health system. People keep saying we don't have hospitals, not because we don't have, but their expectations of healthcare systems have not been met. Next slide. So in the next few slides, to add to what Dr. Stanley already gave us, I'll be giving you some data from our Health Workforce Profile 2018 to just talk more around those challenges I've just spoken about in the previous slide. Next slide. So the first is the stock of health workers in Nigeria. When you look at absolute terms of the number of health workers that we have in Nigeria, take the example of the nurses and midwives. We have over 300 nurses and midwives. This is 2018 data. So by now you can be sure it's much more than these. But by the time you put that beside our population, it's like we have nothing. So right now we have nurses and midwives registered. This is not the numbers that are practicing. There are nurses who have emigrated, who have left Nigeria. There are nurses who are also engaged in other things business, farming, and all those things who are not contributing. But when you look at just the absolute numbers, our ratio is 1 nurse to 1,135. That's very, very inadequate for us. By the time you now break it down into what's happening in the rural areas, what's happening in the northern areas, which I'll show you very soon, you discover that this is a big, big problem in Nigeria. Next slide. I hope this is clear, but just to show you the distribution of health workers in Nigeria, and I've used doctors on the left side and nurses on the left side. Just take a guess. The first 10 are states in the northern part of Nigeria with very, very low doctor to population ratio at 100,000 and nurses to population ratio. You see the distribution is really abysmal. And we have FCT, for example, that have very good ratio, still not the best, because this is 82 doctors to 100,000 population. By the time you break that to 1,000 population, is much less than 1 for even FCT that looks so good. Next slide. To also compound the poor distribution, sorry, this table is really very heavy, but this is showing the distribution of specialists in Nigeria. And I want to make the point around how unequal the distribution is. Lagos alone accounts for about 29% of all specialists in Nigeria. We have 2,204 specialists only in Lagos State. Yes, Lagos has the big population and all that, but we still have a whole lot of people all over Nigeria. We have some states with just 6 specialists, including 1 public health specialist. So you can imagine how the quality of care that we have in those parts of the country. Next slide. A lot has been said about migration. I don't want this presentation to be about migration, but this is just showing us the migration that we've seen. This is, some people have predicted that this happens from time to time. 2007, we had that peak of over 3,500 doctors leaving Nigeria, and it has started some years back also in Nigeria. This is the data as at 2018. The one for the nurses is double what we have for doctors. And in terms of the destination countries, United Kingdom seems to be #1. But these data might be wrong, because we also know in the US, a lot of Nigerians are going in. Some of them go for masters first, and then they go on to practice after their qualifying exam. It's UK that has a very strong system in accounting for health workers from other countries. So that's why we have more data from their hand. Next slide. But this is also something that is, making the shortage that we have even much worse in Nigeria. Next slide. So just to speak a little bit about training, Dr. Azodo mentioned this. We actually, compared to other African countries, we have huge capacity for training health workers. As of 2018, we have 34 accredited medical schools out of 38. About 4 of them did not have accreditation. But from Dr. Stanley's presentation today, we now have more private schools coming up, so over 40 medical schools. And that equates for also schools of nursing and midwifery and community midwifery. We now have more private, the same for community health programs. Now we have a lot of private training institutions also there. But it's still the same problem of poor distribution of these health worker training institutions. 71% of medical schools are in the southern part of Nigeria. And that in effect lead on to the poor attraction and retention of health workers that we see in the northern Nigeria, as I've shown you in that graph for doctors and nurses. The same for schools of nursing midwifery and community midwifery. 10 states have 50% of those schools. 8 of them are in the south. So those are also the poor distribution that is already affecting the retention of health workers in Nigeria. And we need to do something urgently because, as you know, the burden of disease for so many of diseases of interest, the burden of some of those poor indices also reflects the same poor or shortage of health workers that we have in the relative shortage in some parts of Nigeria. And oftentimes we are training in Nigeria, we don't even know how many health workers do we need. Are we overtraining? How many health workers do we need for different cadres in the next 10 years? What are the cadres of healthcare workers we need to concentrate on because of the emigration and things like that? Do we even have the enough capacity to produce enough, both for local engagements as health workers in Nigeria, and also this trend of external migration? I've also talked about the inequitable distribution of health training institutions, comparing North and South. Next slide. So this slide, I hope you can see it, also represents the distribution of schools of nursing and midwifery in Nigeria. And if you take some time, Edo State has about 18 schools of nursing and midwifery. And if you count, about 10 of those states have more than 50%, over 100 health training institutions or schools of nursing and midwifery. Next slide. Very busy slide, but just to show you the absolute huge capacity that we have with these 34 accredited health medical schools in Nigeria. And what is interesting in this table, if you can see, I know it's very tiny, is the increasing number of foreign trained medical doctors coming to Nigeria. In 2018, we had over 800 of them. There is a lot of things we need to talk about, the discussions around these foreign trained health workers and the need in Nigeria. Next slide. So in terms of training, in terms of recruitment, in terms of retention, this is how we think through demand and supply of health workers. What is happening right now? We do not have adequate data to tell us what is the demand and what is the supply. We have some ideas about some production, but in terms of supply, that means the number of health workers who are willing to find appropriate jobs in Nigeria at the level of wages, and compare that with the demand. That's the willingness and the ability of government and private sector to pay those health workers. That's where I think our mismatch is now. Even though we talk about migration, external migration, we talk a lot about how people are moving every day, but we have doctors, nurses who are unemployed in Nigeria or underemployed in Nigeria right now. And those are also major issues that we don't talk about oftentimes. I don't have the evidence, and that's one of the area of work we want to do this year. But already people are already talking about the time it takes to get an internship position for most of the healthcare work that has internship program. How many years or how many months does it take to get internship for a doctor, for example? Years ago, straight from medical school, you get your, to whom it's a concern even before your certificates will come out, you're able to get a house job. But these days, things are different. So it's not just about migration that we are talking about. There's also a mismatch between demand. A lot of people are retiring, a lot of people are leaving. How many of them are being employed? There are states that still have embargo on health workers, and we are training a lot more in the country. There is also the issue of training of some health workforce that there is not enough need or demand for them in the health sector. I went to a state, for example, where they've had this mismatch. They needed nurses, they needed doctors, but they've employed a lot of environmental health assistants or technicians who are now a big population in their primary health care. So all those discussions, these strategic discussions, I think we've not been having it, especially at the state level where these issues are coming up. Next slide. So oftentimes, we don't speak the language of politicians. There are reasons also politicians allude to for not also employing health workers. These are some of those economic factors. And I think Dr. Stanley spoke about it. You can spend more on human resources for health beyond what you're spending on the health expenditure. So the way we reduce the health expenditure or the government public health expenditure or investments in healthcare, the same way it affects the capacity of the system to absorb more health workers. And that also depends on the GDP of the country. If the country is making more money and there is more money to employ more health workers, more money to appropriate and release for the health sector, and more money to devote to personnel recruitment. So we've had about, is it 1 or 2 recessions now? Now we need to also begin to speak with that voice of helping the government and policymakers on identifying the right revenue that will go into investment into health workforce. Next slide. These are also some considerations. The very popular, when we talk about and make advocacy to politicians, to policymakers, we talk about our huge population, and that's where we talk about health worker population ratio, the gender, the fertility issue, very fertile country, a fertility rate, total fertility rate 5.1 or 5.3. So that means every woman wants to have at least 5 children in their lifetime. And also the distribution of the people, a lot of Nigerians living in rural areas where they have poor access to healthcare. We also talk about our disease burden, how we are the headquarters of malaria, NTD, those burden very high, and a lot of demand on the health workers. And now we have epidemics coming up. And coupled with the population and other socio-demographic factors, we've used that a lot to make the case for more recruitment of health workers. But where the decision is made is at governance. It's the economic factor. It's a lot of things that go into making the decision to recruit more health workers. And I think we are at a very good time right now during this transition to make the case for investment in health workers. And we need to have the right data to show what return on investment will be for more health workers employed. We also need our health system to be more transparent, less, people are performing what they are supposed to do. And we also need to embrace technology. People are already talked a lot about telemedicine, talked about so many other areas on technology. We need to start looking at that in Nigeria. Next slide. I have very little time. I would have loved to really go into this, but let's go next slide. These are some of the areas where we work. So what can we do? Some of them, Dr. Azodo already spoke about them. I'll just take some of these strategies from the Global Strategy on Human Resources for Health, the Workforce 2030. Next slide. To talk about HRA training or health workers training, I think we need to rethink the whole system of health workers training in Nigeria. We need to think through what are the transformative strategies in the scale up of health workers in Nigeria. What do we need? What's the population need? Where do we need the health workers? What areas do we want them to concentrate on? And some great ideas are coming, like the community midwifery program that the Nursing and Midwifery Council started. I think it's a great idea. So we need to also think through all that, even for community health extension program. What do we really need from them? How do we also ensure there is interprofessional, good interprofessional practice at all levels, not just secondary or tertiary, even primary? We need the right mix of health workers at those levels. We also need our training curriculum and the capacity in our training institutions to meet the demand of our health workers locally and internationally. How do we ensure that there's a lot that needs to go into that? Our curriculum is here at the same level with other countries. I think they agree because they are taking a lot of our people, but how do we improve on that also? We also need to continue what the regulatory bodies are doing very well in terms of accreditation of those training institutions. But it needs to go beyond just accreditation. It needs to be a way to monitor, to facilitate, and ensure quality are being produced. We also need to link our HRA planning and education. We need to have a proper pipeline for health workers, especially focusing on rural and remote areas. People have talked about citing some of those training institutions in rural areas and encouraging people in rural areas to also be admitted. Next slide. The health labor market it's an open market, and I make this case all the time when people talk about putting policies in place that limit people to move out of the country. People will go to where they are best paid, best appreciated, reduce workload on them. And we need to start putting all those into place. Health workforce is different from other civil part of the civil service or the labor market. It's a talented area, and we need people who can manage them. I will join my voice to Dr. Azodo, who has talked about remuneration. We need attractive remuneration. And this should even happen across North and South. The South is producing a lot of health workers the North do not have. If those remunerations become more attractive, maybe people will find it easier to move to the northern part. And other conditions of service that also retain health workers, there's so many of them that people have used. in the past. Consider reskilling workers from declining areas in the health sector. I give an example of the environmental health assistants in the States. You can give them some time and support, scholarships to ensure all of them go to schools of nursing and midwifery if they have the qualification, or even community health extension workers to change their skills so that they can better serve the people. We need more investment in education and employment of people from rural areas. I've talked about this. The last one is what we already do in Nigeria, compulsory service like NYSC, but it's still limited to those who went to the university or those with HND. We need it for those with our RN, registered nurses and registered midwives, so that they can also spend 1 or 2 years providing those services. We also need to rethink our employment contracts and also the care delivery models at especially primary health care level. I'll stop here. Next slide. To say that the Nigerian health sector cannot develop beyond the state of its of our human resources for health. We're plagued with shortage and inequitable distribution of health workers, north, south, rural, and urban. And we also have inadequate investment in human resources for health. We have a national HRA strategy plan, but it's not well resourced and not well implemented, especially at sub-national levels, which in my opinion, we have majority of those challenges. Our human resource for health planning is not linked to evidence-based planning at all, especially in terms of training of health workers. Can we project how many health workers we need? What kinds of health workers do we need to cater for this new population and new characteristics of Nigerians? I think those are areas that we need to devote ourselves to in the coming years. Thank you for inviting me. Sorry for taking so much time.
Thank you, Dr. Ojo. Really appreciate your interventions there as well. And I think that's a good segue into our last presenter, Dr. Kayode Afolabi, who will speak to the place of self-care and task shifting, task sharing policy in addressing the HRH challenges in Nigeria. Dr. Afolabi needs no introduction, but maybe if we could pull up his bio for those who might be new to him. Great. So I'll just go through this quickly because we're up against time. But Dr. Kayode Afolabi holds a bachelor's degree in medicine and surgery and a master's degree in health economics. He also had a fellowship from the West African College of Surgeons in obstetrics and gynecology. He has 33 years of experience in the field of family planning, reproductive and maternal health. And within this period has held several key posts, including as Honorable Commissioner of Health to the Oyo State government. And during this time, his work included health system strengthening with a focus on human capacity development and ensuring health commodity security. He has also worked with the federal government of Nigeria as a director within the Federal Ministry of Health, and has worked partnered with several civil society organizations, the private sector, United Nations agencies, donors, and implementing partners. Not too many people are better placed to speak to the topic he'll be talking on, having had a front row seat to some of those issues at both the federal and subnational level. So Dr. Afolabi, thank you for your time, and we look forward to your intervention. Thank you.
Very much, Jonathan. Can I have my slides on, please? I would also like to thank all the presenters who have spoken before me. In fact, a number of issues relevant to the sub-team of the role of self-care and task sharing policy in addressing the challenges around human resource for health with a view to meeting universal health coverage have been addressed by the earlier speakers. from Dr. Stanley to Dr. Zodo and Dr. Olumiwa. So I thank you very much. Yeah, why addressing this sub-theme of the webinar, tax treatment, tax sharing policy, and self-care in addressing the human resource challenges? Look through the tax treatment, tax sharing policy itself, how it was adopted, the implementation so far, and what we have recorded as achievement as a country on implementing tax treatment, tax sharing policy. Then I also bring to us emerging issues around self-care and the nexus between self-care and digital health. Then we look at performance measurement for self-care before I come down on some considered recommended next steps for Nigeria on tax treatment, tax sharing, as well as self-care implementation in the country. Now I have the next slide, please. Some of the critical barriers to accessing healthcare in Nigeria have really been addressed, particularly shortage of healthcare workers, as well as maldistribution of the available healthcare worker. And now this has been made worse by massive migration, the popularly known Japa syndrome. Many countries in Africa and some countries in Asia actually have similar experience with Nigeria on challenges around human resource for health. And a number of them adopted tax treatment, tax sharing policy. So Nigeria also adopted the tax treatment, tax sharing policy in 2014. And since then, a lot have really been done in regard to implementation of tax treatment, tax sharing policy. Let me have the next slide, please. And when we're talking of tax treatment, tax sharing policy, let me say that the tax treatment, tax sharing can actually be used interchangeably, and that was what was adopted by Nigeria government when it was introduced. So generally, it refers to national redistribution of tax among health workforce and movement of specific tasks, where this is considered by evidence from highly qualified health workers to other health workers who have had shorter training and fewer qualifications. So that at the end of the day, we'll be able to make more efficient use of the available human resources for health. And the overarching goal of tax treatment, tax sharing policy is actually to get the right workers with the right skills, in the right places, doing the right things expected of them. There are strategic objectives to this policy, and these include actualizing the human resource for health workforce need of the country, outlining the essential healthcare tasks that can be performed by different cadres, particularly the frontline healthcare workers, as well as providing framework for them to have their capacity improved. They view to rapidly expanding access to service delivery, and also promoting the best use of competence and expertise of our health worker, and promoting efficiency and effectiveness in the utilization of the resources we have at our disposal. Let's go to the next slide. When tax treatment, tax sharing policy was adopted in Nigeria, the main focus was on family health department programs and projects. But now it has gone far beyond that. Why the focus was on family planning, family health program, family planning, adolescent sexual and reproductive health and rights were actually well focused. But there was also attention on safe motherhood, newborn and child health care. Currently, we have actually expanded to include more cadres of healthcare providers, especially the community pharmacists and the patent proprietary medicine vendors. And there are very good efforts on expansion to include non-communicable diseases. While implementing tax-free sharing policy, a lot have been achieved. And this includes ensuring strong enabling environment for the new cadre of healthcare providers on the task that will be shared with them. So government and stakeholders put together necessary training manual that focus around competency-based training, particularly for long-acting reversible contraception. And this was backed up with post-training supportive supervision manual so that this could guide supervision and mentoring of the cadres on the new tasks that have been shared with them. Also, stakeholders were able to put together a modified life-saving skill manual for the community health extension workers. And the curriculum they were using in the pre-service area were also revised to accommodate these new tasks that have been shared with them. Of course, we know how cost-effective the training curriculum review will be when this is well implemented. Next slide, please. So the other very important area where we demonstrated some good impact is when we look at the data on long-acting reversible contraception. Before the adoption of tax-free sharing policy, about 121,000 annual uptake of long-acting reversible contraception. But by 2018, after we have implemented tax-free sharing policy for about 4 years, this uptake rose to almost 1.6 million annually. And this was actually made possible because we are able to man various service delivery points that are not providing family planning services because of lack of skilled provider before the implementation of tax-free sharing policy. For instance, in the year 2013, we had only 3,000 of our PHC service delivery points for family planning. So we are able to increase this to 20,000 by the year 2018. This was a dramatic improvement. I accounted for the increase in the uptake of long-acting reversible contraception. So let's quickly look at self-care and digital health. Next slide, please. So self-care, we are getting familiar with it gradually. But according to WHO, self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability, with or without the support of a healthcare provider. And this cuts across main part of a system that has to do with everyday life, including self-management, self-testing, and self-awareness. May I have the next slide? So the self-care interventions were adopted in Nigeria in the year 2021, following the approval of the Honorable Minister of Health. And this also followed the recommendation from WHO in June 2019. These are the areas that self-care intervention actually covered. We are talking of issues around antenatal care, delivery services, as well as postpartum care, including newborn care, which is a very delicate period where we have lots of morbidity and mortality that are still making our health indices to remain poor as a country. Also, provision of high-quality family planning services, eliminating unsafe abortion, that also contribute to high maternal morbidity and mortality, as well as combating sexually transmitted infections, including HIV, and cervical cancer, which is also considered as an offshoot of a sexually transmitted infection. So generally, self-care promotes sexual health, and there are a lot of several cross-cutting issues that we briefly consider as part of emerging issues on self-care globally and also in Nigeria. And of course, there is this strong governance structure to guide self-care intervention from key principles through places of access to self-care and ensuring enabling environment and accountability, strong accountability framework, so that the whole process will not be poorly understood and will not be open to abuse. Next slide, please. So as a country, the national guideline on self-care for sexual, reproductive, and maternal health that was approved by the Honorable Minister of Health for implementation covers these strategic areas that will help address our morbidity and mortality and help improve our health indices, as well as driving us towards achieving universal health coverage. Let me have the next slide, please. So there are some critical thematic areas that government at the national and subnational level must really pay attention to if our implementation of self-care in the country really reach the people that need to benefit from it and contribute its own impact to universal coverage. Demand generation and social behavior change is quite very key, being an emerging area. And this will enhance service delivery. But once there's awareness and we create demand, then we'll be able to reach the people and expose them to channels of access for service delivery. Then supply chain issues and financing, which of course will require strong advocacy, are also very important. And we need to measure whatever we are doing so that we can track our progress on self-care in the country. Let's go to the next slide. So as a country, we used self-injection of GNPSC, that is Press, as the entry point for self-care, and also forms the foundation to accessing or to implementing other areas of self-care in the country. Of course, we know that our people accept injectable contraception far more than other contraceptive methods. And of course, this also gave us the opportunity to leverage the availability of GNPSC and its game-changing features as our foundation for self-care in the country. So let's look at various channels of access in the next slide for self-care intervention. And of course, it's very important for us to realize that access to self-care intervention improves autonomy of people. These are different channels that are available for people to access self-care, right from individual to family, friends, and community, through digital platforms and various digital technologies that are available presently in the pharmacy shops, and a linkage to a facility through the primary health care and to higher level as may be required. Different channels of access for self-care that have been proven and recommended by WHO. Let me have the next slide, please. Measurement is key to tracking and documenting our progress, especially as self-care is relatively new. You need very strong guide on performance framework and thanks to the measurement subcommittee of self-care trailblazer group that developed a standardized guide for monitoring, learning, and evaluation of self-care intervention. This was just recently done in the first quarter of this year. And this framework focuses on 3 specific interventions, including DNPSC self-injection, that is anapres self-injection, HIV self-testing, and self-managed abortion. Don't let's forget that in Nigeria, abortion care is allowed only for post-abortion care. Otherwise, every other aspect of abortion care may remain illegal as of situation today. So this tool included a set of priority indicators for each of the interventions. Next slide. Let's look at the domain of self-care measurement. And this includes the level of policymakers, legislators, and regulators who are expected to create the enabling environment. So they are indicators targeting the enabling environment and responsibilities of these senior level officers in the healthcare management. And from them to the health workers and managers who are to be responsible for service delivery and health outcomes. What exactly is the performance at this level? The indicators provided here provide us to be able to measure such performance. And finally, the self-carers, which is the individual and the caregiver. The indicators recommended in this domain are on knowledge, attitude, and practices of self-care. Next slide. I was quite very happy when Dr. Zodo was discussing around digital health. And of course, it is applicable to different aspects of healthcare delivery, including self-care. And there is a strong nexus between self-care as well as digital health when it comes to issue of access. Let me have the next slide. Dr. Zodo had exhausted issues around this. So many health practices that were once in the full control of healthcare professionals can now be safely self-administered. And this is even made stronger by availability of new commodities and drug regimen for self-management, self-testing, and self-awareness. Then when we now look at the expansion of mobile phones, smartphone application, internet penetration, as well as availability of artificial intelligence, we realize that we have massive opportunity with digital health for us to actually have to think on ways to engage our people on self-care. And of course, with this major shift in mind, I think it provides the managers of healthcare that strong opportunity to governments and partners. We need to leverage the expansion of digital platforms to enhance self-care. And of course, if we extend this further, it may actually help to reduce stigma and discrimination that could be faced by certain group of people when they seek healthcare services from the former healthcare system. For instance, when we look at issues gender-related and of course gender-related disparities. Let's get to the next slide, please. Next slide. Yes, so on gender related disparities, there is a very big and emerging role for self-care, which we include promoting gender responsive and inclusive system that will meet the unique needs of everyone and we permit spectrum of gender identity that is acceptable legally
Hello. Hello, Dr. Afolabi, are you there? Yeah, okay.
Hello? Yeah.
Yes. Go ahead.
Apologies for that short break. Yes. So we're talking of promoting gender responsive and inclusive health system, as well as ensuring that we focus attention on relevant areas of research that will actually help to address gender-related disparities, and of course, advocacy for policies and programs that promote gender equity. I imagine areas that we should be considering on self-care, and this also will be a very strong role that self-care may be playing in ensuring universal health coverage for our great country, Nigeria. Can I have my next slide, please? So before I round off, let me bring up these recommended next steps on self-care, as well as tax-free sharing policy. Because of the emerging issues, our current self-care guideline may actually require revision, and government and stakeholders should take note of this. Partners, we also need to support government at various levels for implementation, as well as measurement of self-care, which is still quite very new. But of course, if you don't get what we are doing measured, like we are not reporting any progress. On taxable tertiary policy, the coordination has been good. We need to sustain this and make it very effective. Also ensure that it embraces the community pharmacists who have just been fully placed on the taxable tertiary policy, as well as the 3 tiers of patent and proprietary medicine vendor. The 3rd edition of taxable tertiary policy needs to be launched and widely disseminated for the states to be aware of this, and also implement in accordance with the thematic areas of that policy. Finally, government and partners, we need to finalize the community pharmacist and PPMV protocol and supervisory checklist so that we could guarantee the quality of care that this cadre of officers who have thus been fully embraced to taxable tertiary implementation I will be providing. So let me have the last slide. I'll be concluding by saying that time waits for no one. 2030 will soon be here, and we'll be faced with measuring what we have done and what we have achieved concerning universal health coverage. I'm sure that none of us here will want our country health indices to remain as poor as it is, especially among the vulnerable people. As we are discussing at this webinar, for every 1 hour we have spent, about 7 women must have died of preventable death. If we fully implement taxable tertiary policy and self-care, it can stop the road to death for many of these Nigerians, and will be enhancing universal health coverage. Thank you very much. And I'll be willing to entertain questions and comments. Over.
Thank you very much, sir. Very, very rich presentation from you and the rest of our panelists. I'm aware that we are 22 minutes over time, but I know that this has been a very rich presentation. So can I confirm with the panelists that maybe we can take 1 round of questions with the aim to wrap up in the next 8 minutes on the hour? Is that okay with everyone? Okay, great. So I wonder if there are any questions from the floor, from the audience. I don't see any. Actually, I see one now. For Dr. Afolabi, there's a question for you from Heritage Fatimikun that says, how can self-care be leveraged to mitigate the issues of HRH in Nigeria? You spoke a bit about that, but I wonder if you could provide some more color on that.
Yes, I thank Heritage for asking that question. That's actually been the main focus of this discussion on the place of self-care in our addressing human resource for challenges. So if we have strong health awareness, which is the first point on self-care that I want to mention now, we realize that a number of diseases are actually be prevented by individuals. So self-awareness through health education, health promotion can actually make us to be healthy and prevent number of diseases. And when we now look at self-testing, there are a number of basic tests that we can do as individual if we follow the rule or the guides of self-care, and that could reduce burden on the health system. There are also a number of some basic care we can give to ourselves, and some of them we can just commence before we go to the health facility. Look at digital health. There are a lot of opportunity through awareness, creation of digital platform that could actually make you remain healthy if you follow them. And of course, if all of us do that, it will reduce the burden on the human resource, reduce number of people that may have to seek care because many people will remain healthy. And sometimes, if we could look at sexual and reproductive health, and let me use self-injection of Cyanapress as an example. What is approved in the country is that once a woman is trained to self-inject and is given the first dose at the health facility, the woman can go home with enough doses to last her for a whole year, so that she will not need to come back until a year for review if she's to go or to continue on the particular family planning method. Unlike without self-care, this woman will have to be coming repeatedly every 3 months. So you can imagine the number of acceptors of injectable contraception that we not need to report to the health facility repeatedly in a year. So all this reduces the burden on the healthcare worker and allow them time to focus on more critical areas of need. Thank you.
Great, thank you very much, sir. Are there any other final questions? Otherwise, I'm happy to give the last word to our technical experts on the line, Drs. Ojo and Stanley Ukpai. It seems like Dr. Azodo has dropped off, but maybe for Dr. Ojo and Dr. Ukpai, I'll give you the last word, and maybe if you could answer this question. If you were a strategic advisor to the Minister of Health, the incoming Minister of Health, what would you, what are 1 or 2 recommendations, maybe from what you've shared, that you would resurface as priorities in the first 100 days to sort of stem the brain drain, as it's called, of health workers? And maybe we can end on that note.
Thank you very much, Jonathan, for that question. And perhaps I'll go first before Dr. Ojo comes in. I think for the incoming minister, in his first 100 days, there is already an advantage because in the 2023 budget, there is a budget line item that speaks to the health sector brain drain and provision for training of more health facilities. So he's not exactly starting from zero. So that's a plus. I also think it's important for him to address some of the causalities of the brain drain, one of which is the remuneration part. And this he can do in collaboration with private sector if the Labour Ministry isn't willing to have concessions on that. He can begin to have conversations with private sector on how they can increase their investment in health. given that the budget is still not up to 15% for 2023, this is something that he can explore to address that wage gap. I think finance is one of the pivotal drivers of people outside this country, even people living internal. There is some certain level of internal migration where people live working in hospitals to working for private sector, even development communities, and that is ongoing. So all of that still affects the availability of health workforce that we have that caters to health needs, and on this borders on our achievement on for universal health coverage in 2030. So if he can address that wage gap and he can start to look at increasing the entry level of potential people who would service the health workforce in training institutions, I think these two things can help us get on our way. On a more long-term thing process, we can begin to look at the environment, the facilities, and also bilateral agreements with destination countries where these people are migrating to, and see how we can form a brain transition as opposed to a total brain drain. So for the first 100 days, focus on the causalities, which is the finance. It's very, very important. Increase the uptake in our production line, so we have more healthcare workers coming through all the various cadres of the health care worker profile. Over.
Great, thank you. And I think the point you raised on internal migration is really important as well. Dr. Ojo, last word to you, please.
I think Dr. Stanley took the word right out of my mouth. And yes, number one, around migration, we need to have that discussion. Dr. Azodo talked about it, bilateral agreements with countries, and that's what is becoming a world best practice. We have examples from Philippines that has the bilateral agreement with other countries. There are also other things we can benefit from those countries where our colleagues are going to. So that's something we need to look at. But it's not a one size fits all. There are several levels that need to come into place, several policies that we need to think through on what this will mean for Nigeria. We've made that point. You can't stop people from going. So what can we do to retain? What can we do to also make that movement to be very ethical and in a way that does not distort the services that we're providing? And also remuneration. I spoke about this as much as possible, and we need to create that database of all health workers that are available in the country so that we know how to quickly recruit and also put those retention strategies in place. I'll stop here. Thank you.
Great. Thank you very much, Dr. Ojo. It's a great point to end on. So can I turn to Mr. Olukunle for the final closing remarks and to thank our panelists?
Okay, thank you very much, Jonathan, for that moderation. I think I need to appreciate you for the wonderful work that you did today. We really appreciate that. I said today webinar is actually a wonderful webinar that gave us an insight and understanding around the issues of HR for health challenges and universal health coverage in Nigeria. And I would like to appreciate all our speakers, our panelists, for that wonderful presentation. There's a lot of things that we learned today, and I believe this will continue because we have a lot of gaps that we can see and a lot of recommendations that we need to follow up to see how Nigeria can move from where we are today to the next level that can improve our human resources for health and can also improve our universal health coverage in Nigeria. So let me use this opportunity on behalf of the leadership of ACIE Foundation and the other arm of the ACIE Foundation to appreciate Dr. Stanley, Dr. Azodo, Dr. Ojo, and Dr. Kayode Afolabi for that insight and for that knowledge they have imparted on this webinar to everyone that participated in this meeting. And also, I will not forget to mention also the moderator for that skills and experience in coordinating this webinar. It's really good, and it shows a lot of experience and that we appreciate you, Mr. Jonathan, for that. I would like also to congratulate my colleagues in ACRE Foundation and also ACRE Association for their wonderful contribution. Actually, many of us work behind the scene, but you can see the success, and I would like to congratulate everyone, right from the senior management to all the staffs of ACRE Associates and the foundation for the wonderful work that we do today. I believe this will be a continuous process and a continuous meeting that will make to actually take what are the issues in Nigeria to address, and will come with our knowledge and bring expertise to discuss this and to actually expatiate and open the eyes of the leaders in this country to do more in the area of health program and health system strengthening in Nigeria. So on that note, I would like to say thank you, everyone. And I believe all our speakers will still call you again. You still come to support us and to attend to these kind of issues that are burning issue in this country. Thank you, and God bless you. Over.
Great. Thank you all. Have a great day.